You are spending money on supplements that are doing nothing. Not because the science is wrong, not because the ingredients are fake, because the one thing that determines whether a supplement works or becomes expensive urine, the one variable that the supplement industry has spent billions of dollars hoping you never learn, is something that has nothing to do with the label on the bottle. I am Dr. Amelia Carter. I have been in cardiovascular medicine for 20 years. And I want to tell you something that does not appear in any supplement advertisement, in any pharmacy aisle, or in the 6 minutes your doctor has to review your medication list. Most people taking supplements after 60 are making the same mistake. One mistake. And it is not choosing the wrong supplement. It is not taking too much or too little. It is something far more fundamental than that. It is the assumption that the supplement you swallow is the supplement your cells receive. It is not. Between the pill you take and the cell that needs it, there is a process called absorption. And after the age of 60, that process has changed in ways that invalidate almost every supplement recommendation you have ever received, because those recommendations were designed for a 35-year-old gut, a 35-year-old liver, a 35-year-old cell membrane. You are not 35, and your supplements do not know that. I am going to show you exactly what is happening to that supplement between the moment you swallow it and the moment it either reaches your cells or fails to. And I am going to show you the specific adjustments that turn a supplement from expensive urine into a genuine clinical intervention. But I need you to understand something first, something that changes everything about how you read a supplement label. Because if you do not understand this one mechanism, everything else I tell you today will not land the way it needs to. I want to tell you about a man named Leonard. Leonard is 68 years old, a retired civil engineer, methodical, precise, a man who reads the instructions before he opens anything. When his doctor told him his B12 was low, Leonard went home and researched it carefully. He bought the highest-rated B12 supplement on the market, 2,500 micrograms per tablet. He took it every morning with his coffee. He had his B12 rechecked 6 months later. It was lower than before. He came to my office not angry, but genuinely confused. He showed me the bottle. Premium brand, no fillers. His research had been thorough. He had done everything right, everything except one thing. Leonard was on a proton pump inhibitor for reflux. Had been for 4 years. He had never been told, by his prescriber, by his pharmacist, by anyone, that his stomach acid medication was blocking the very mechanism his gut uses to absorb B12. He was taking 2,500 micrograms of a supplement that his body could not use every single morning for 6 months. Leonard's story is not unusual. It is typical. And the reason it keeps happening is that the supplement conversation and the medication conversation almost never happen in the same appointment, with the same awareness of how one affects the other. The supplement industry operates on one assumption, that absorption is a given, that if you swallow something, your body processes it. In a young, unmedicated adult with a healthy gut, this is roughly true. In an adult over 60 on multiple medications with age-related changes to gastric acid, gut motility, liver enzyme activity, and cell membrane composition, it is frequently not true at all. The hard truth: here is the clinical reality nobody puts on a supplement label. After 60, gastric acid production declines by 30 to 40%. The acid that your stomach produces is not just for digestion. It is the chemical environment that unlocks the absorption of iron, B12, magnesium, calcium, and zinc. Reduce the acid and you reduce the absorption, not by a little, but in some cases by more than half. Add a proton pump inhibitor on top of that natural decline, and the absorption environment for those 5 nutrients is severely compromised, not occasionally, every time you take the supplement. That is the mechanism that Leonard's doctor did not have time to explain. That is what this video exists to show you. Before I take you through the 5 most commonly wasted supplements after 60 and exactly how to fix each one, I want to establish something. Because this video is not about frightening you away from supplements. Supplements, used correctly, are among the most powerful tools available for seniors managing chronic conditions. The data is there. The biology is there. The problem is not the supplement. The problem is that the instructions on the label were written for someone else's body. After this video, you will know how to rewrite those instructions for yours. 3 types of people are watching this right now. The first type is taking supplements, feels like they are doing something responsible for their health, and has never questioned whether those supplements are actually reaching the cells that need them. This video is a wake-up call, not a frightening one, a useful one. The second type is taking supplements and also taking 1 or more prescription medications. You are the most important person watching, because the interaction between what is in your supplement bottle and what is in your prescription bottle is almost never discussed, and it is determining whether either of them is doing what it is supposed to do. The third type has stopped taking supplements because they tried them, felt nothing, concluded they did not work, and gave up. I want you to hear this. They may not have worked because of how they were being taken, not because the biology is wrong. Stay for the protocol section. Because what I am going to show you may give you reason to try again differently. There are 5 supplements that seniors take more than almost any others: vitamin D, magnesium, B12, iron, and omega-3. For each one, I am going to show you the mistake most people make, the specific reason it is happening, and the exact correction that changes the outcome. But I need to tell you about number 3 before we get there, because number 3 is the one that has a silent thief. A thief that is taking what you paid for before your cells even have a chance at it. And if you are on a medication that is in the top 20 most prescribed drugs in America, that thief may be operating in your body right now. Let me take you through each one, and I want you to listen for yours. Mistake 1. Taking vitamin D without K2 and without fat. Vitamin D is the most commonly recommended supplement for adults over 60. Bone health, immune function, cardiovascular protection, the evidence base is substantial and legitimate. But here is the mistake. Most people take their vitamin D in the morning with a glass of water, and most people take it without K2. Both of those things are wrong, and both of them are costing the supplement its effectiveness. Vitamin D is fat-soluble. That sounds like a technical detail. It is not. It means that without dietary fat present in the gut at the time of absorption, the vitamin D molecule cannot cross the intestinal wall. It has no carrier. It passes through. A 2015 study published in the Journal of the Academy of Nutrition and Dietetics measured vitamin D absorption in subjects who took it with a fat-free meal versus a fat-containing meal. The fat-containing meal group absorbed 32% more vitamin D. 32%. From the same dose, simply because of what was on the plate. The solution is not complicated. Take vitamin D with your largest meal of the day, the meal most likely to contain some fat. Eggs, olive oil, avocado, nuts. Any of these create the absorption environment the vitamin requires. Now, the K2 problem. Vitamin D's job is to increase calcium absorption from the gut into the bloodstream. It does this with extraordinary efficiency. What it does not do, what it is physiologically incapable of doing, is tell that calcium where to go once it is in the blood. That is K2's job, specifically a form of K2 called MK7. K2 activates 2 proteins, osteocalcin, which directs calcium into bone, and matrix GLA protein, MGP, which actively prevents calcium from depositing in arterial walls. Without K2, vitamin D floods your bloodstream with calcium, and that calcium goes wherever the physics of your individual vascular environment takes it. In many adults over 60, that means arterial walls, joint tissue, kidney stones. The Rotterdam study, which tracked over 4,800 adults for 10 years, found that people with the highest vitamin K2 intake had a 57% lower risk of dying from heart disease and 52% less aortic calcification than those with the lowest intake. 57%. From a vitamin that most of you have never been told you need alongside the one you are already taking. Dose: 100 to 200 micrograms of K2MK7, not MK4, MK7, taken with the same fat-containing meal as your vitamin D. Important, do not skip this. If you are on warfarin or any vitamin K antagonist blood thinner, do not add K2 without telling your prescriber first. K2 affects clotting factor activity and will interact with your anticoagulant therapy. This is not optional. This is the one conversation you must have before you purchase this supplement. Mistake 2. Taking the wrong form of magnesium. Magnesium is involved in over 300 enzymatic reactions in the human body. Muscle contraction, nerve signal transmission, blood sugar regulation, cardiac rhythm, sleep architecture. It is not optional, it is infrastructure. And most people taking magnesium supplements are taking a form that their gut cannot absorb efficiently. The most common magnesium supplement sold in pharmacies is magnesium oxide. It is the cheapest to manufacture. It is on the shelf of every store that carries supplements. And studies suggest that as little as 4% of magnesium oxide is actually absorbed by the human gut. 4%. That means if you are taking a 400 milligram magnesium oxide tablet every morning, your body is receiving at best approximately 16 milligrams of usable magnesium. The label says 400 milligrams. Your cells receive 16. The form matters enormously, and the forms are not interchangeable. Magnesium glycinate, bound to the amino acid glycine. Absorption rates in clinical studies range from 50 to 80%. It also has a mild calming effect on the nervous system because glycine is itself an inhibitory neurotransmitter. This is the best form for people taking magnesium for sleep, muscle cramps, or anxiety. Magnesium malate, bound to malic acid, which is involved in the Krebs cycle, the cellular energy production pathway. Best form for people taking magnesium for energy, fatigue, or fibromyalgia-type symptoms. Magnesium threonate crosses the blood-brain barrier more effectively than other forms. Emerging evidence for cognitive support, most expensive. Worth considering specifically for anyone with memory or cognitive concerns. Magnesium citrate, moderate absorption, laxative effect at higher doses. Useful for constipation alongside magnesium support, but not ideal as a primary supplementation form. The timing also matters. Magnesium's primary roles in sleep architecture and muscle relaxation make it most effective when taken 60 to 90 minutes before bed. Not with breakfast, not mid-afternoon, before bed. If you have been taking magnesium in the morning and wondering why your leg cramps continue at 2 a.m., this is why. Now we get to number 3, the one with the silent thief. And I want you to pay particular attention to this one if you are on a heartburn medication, a blood pressure medication, or a diabetes medication, because one of those 3 may be intercepting the supplement you are taking before your cells ever see it. Mistake 3. Taking B12 when your gut can no longer absorb it. This is Leonard's mistake, and it is the most consequential mistake on this list, because B12 deficiency does not announce itself with a blood test until significant depletion has occurred. And by the time the standard serum B12 reading falls below the laboratory reference range, neurological and cardiovascular consequences may already be accumulating. B12 absorption is a 2-step process. First, stomach acid separates B12 from the food protein it is bound to in your diet. Second, a protein called intrinsic factor, produced by specific cells in the stomach lining, binds to the free B12 and escorts it to the absorption site in the small intestine. Both of those steps require adequate gastric acid. Here is where the thief enters. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, dramatically reduce gastric acid production. That is their mechanism. That is how they treat reflux. But the same acid suppression that calms your heartburn is simultaneously impairing both steps of B12 absorption. Metformin, the most widely prescribed diabetes medication in the world, independently reduces B12 absorption through a separate mechanism involving calcium-dependent transporters in the gut wall. H2 blockers, famotidine, ranitidine, have similar but less severe effects. The result is a patient who is taking B12, whose B12 levels are being routinely checked, whose results come back within the normal range, and who is nonetheless functionally B12 deficient at the cellular level. How is that possible? Because the standard serum B12 test measures total B12 in the blood, including B12 that is bound to transport proteins and biologically inactive. A patient can have a normal serum B12 while their cells are starving for the functional form. The test that reveals the truth is methylmalonic acid, MMA. MMA is a metabolic byproduct that accumulates when B12 is functionally deficient at the cellular level. When serum B12 looks normal but MMA is elevated, functional B12 deficiency is present and operating. This test is not part of a standard panel. It must be specifically requested. And in the many patients on long-term PPIs or metformin who have never had it run, the result is often a revelation. The absorption fix for B12 is specific. Standard oral B12 supplements rely on the same intrinsic factor pathway that the medication is blocking. They will not reliably work in patients with significantly suppressed gastric acid. Two alternatives bypass the gut pathway entirely. Sublingual B12. Tablets that dissolve under the tongue and absorb directly through the oral mucosa into the bloodstream. No intrinsic factor required, no gastric acid required. Forms: methylcobalamin or adenosylcobalamin, not cyanocobalamin, which requires hepatic conversion and is less bioavailable in older adults. Intramuscular B12 injection, the clinical gold standard for patients with confirmed pernicious anemia or severe absorption impairment. Administered by a healthcare provider, completely bypasses the gut. If your B12 has been declining despite oral supplementation and you are on a PPI or metformin, this conversation with your prescriber is overdue. Before I get to mistakes 4 and 5, I need to show you something about the way these 5 mistakes interact with each other. Because there is a specific combination that affects a very large number of seniors on multiple medications, and understanding it is more important than any individual supplement error. The hard truth, the combination problem nobody models. A senior on a PPI is absorbing less B12, less magnesium, and less iron simultaneously. The same senior on a loop diuretic is excreting extra magnesium, potassium, and calcium with every dose. The same senior on a statin has reduced CoQ10 production, affecting every energy-dependent process in the body, including the cellular mechanisms that use the supplements they are taking. 3 common medications, each one individually altering the absorption, retention, or utilization of the supplement sitting beside them on the nightstand. No single prescriber is modeling this as a system. No supplement label warns for it. And the patient is left wondering why the supplements they are faithfully taking are not doing what the internet said they would do. Mistake 4. Taking iron without understanding what blocks and what enhances. Iron deficiency is the most common nutritional deficiency in the world. In seniors over 60, it is particularly insidious because it presents as fatigue, cognitive slowing, and reduced exercise tolerance, all of which are easily attributed to aging. Many patients are diagnosed late, started on iron supplements, and then do not improve because of the absorption environment around those supplements. Iron absorption is exceptionally sensitive to co-ingestion. And the things that block it are the things that most people are taking alongside it. Calcium blocks iron absorption. They compete for the same intestinal transporter. Taking iron with a glass of milk with a calcium supplement or alongside a calcium-containing antacid can reduce iron absorption by up to 62%. Many seniors are taking a calcium supplement for bone health and an iron supplement for anemia simultaneously, in the same glass of water, with the same meal. They are blocking each other. Coffee and tea contain tannins and polyphenols that bind to iron in the gut and render it unabsorbable. The cup of coffee that accompanies the morning supplement routine is sequestering the iron before the gut has a chance at it. The separation required is a minimum of 1 hour. Most people do not wait 1 hour. Proton pump inhibitors appear again here. Gastric acid converts dietary iron from the ferric form to the ferrous form, which is the absorbable form. Reduce the acid and you reduce that conversion. Iron that was ferric stays ferric. Ferric iron passes through the gut without being absorbed. What enhances iron absorption? Vitamin C, specifically 100 to 200 milligrams of vitamin C taken alongside the iron supplement converts ferric iron to ferrous iron in the gut lumen, independently of gastric acid. This is the supplementation intervention that partially compensates for the PPI absorption deficit. Take your iron supplement with a glass of orange juice or with a vitamin C tablet. Take it on an empty stomach if tolerated. Take it at least 2 hours away from any calcium supplement, antacid, or PPI dose. And request your ferritin alongside your serum iron when you are checking levels. Serum iron fluctuates daily. Ferritin, the storage form of iron, reflects the body's actual iron reserve. Many patients with symptomatic iron deficiency have serum iron within the normal range. Their ferritin tells the real story. Mistake 5. Taking omega-3s. Without understanding form, dose, and the inflammatory context, omega-3 supplementation has among the strongest evidence bases in nutritional medicine for cardiovascular outcomes. The REDUCE-IT trial, involving over 8,000 patients with elevated triglycerides and established cardiovascular disease, found that high-dose omega-3, 4 grams per day of EPA, reduced major cardiovascular events by 25% compared to placebo. 25% from a supplement. So why do most people taking omega-3s not experience that level of benefit? 3 reasons: form, dose, and baseline inflammatory context. Form. Most omega-3 supplements sold in pharmacies and health stores are in the ethyl ester form. Ethyl ester omega-3s are significantly less bioavailable than triglyceride form omega-3s, the form found in fish themselves. A 2012 study in prostaglandins, leukotrienes, and essential fatty acids found that triglyceride form omega-3 was absorbed 70% better than ethyl ester form. The label will tell you the EPA and DHA content. It will rarely tell you the form. Look for the words triglyceride form or reesterified triglyceride. If it does not say this, it is almost certainly ethyl ester. Dose. The standard pharmacy fish oil capsule contains 300 milligrams of combined EPA and DHA. The REDUCE-IT trial used 4,000 milligrams per day of EPA alone. These are not comparable. A 300 milligram capsule taken once a day is not a cardiovascular intervention. It is a gesture. For a genuine omega-3 effect on triglycerides, inflammation, and cardiovascular risk, the therapeutic dose is 2 to 4 grams of combined EPA and DHA per day. This is a prescription-level dose and should be discussed with your prescriber, particularly if you are on anticoagulants. Baseline inflammatory context. Omega-3 works by competing with omega-6 fatty acids for the same enzymatic pathways. The ratio of omega-6 to omega-3 in the modern diet is approximately 15 to 1. The ratio at which omega-3's anti-inflammatory effects are clinically meaningful is closer to 4 to 1. No omega-3 supplement at any dose will achieve a therapeutic ratio in a patient whose diet is saturated with refined seed oils, sunflower, corn, canola, soybean, that are dense in omega-6. You cannot supplement your way out of a diet that is actively working against the supplement. Reduce the omega-6 load first. Then the omega-3 supplement has room to work, and take it with the meal that contains the most fat. Omega-3, like vitamin D, is fat-soluble. Its absorption is enhanced by co-ingestion with dietary fat. An empty stomach is where omega-3 supplements go to accomplish nothing. Let me give you the corrected protocol. Not in the abstract. In the practical specific form that you can implement starting tomorrow. With your largest meal, the one that contains the most fat, vitamin D, taken with fat. Not water alone, K2, Mk7, 100 to 200 micrograms, taken alongside the vitamin D. Fat present, omega-3, triglyceride form if available. 2 to 4 grams combined EPA/DHA for therapeutic effect discussed with prescriber for doses above 2 grams. 60 to 90 minutes before bed. Magnesium glycinate, 200 to 400 milligrams, not oxide. Glycinate or malate. Away from all other supplements, on an empty stomach or with vitamin C, iron if supplementing. at least 2 hours away from calcium, coffee, and PPI dose, with 100 milligrams vitamin C. Under the tongue, not swallowed, if on a PPI or metformin, B12. Sublingual methylcobalamin or adenosylcobalamin, not cyanocobalamin. And the conversation to have before any of this, a review of your complete medication list for interactions with each supplement. Not a general conversation about supplements, a specific question about each one. Your exact words at your next appointment. I'd like to review my supplement regimen in the context of my current medications. Specifically, I want to understand whether any of my prescriptions are affecting the absorption or utilization of B12, magnesium, iron, or vitamin D. Can we run a methylmalonic acid level alongside my standard B12 to check for functional deficiency? And I'd like to discuss whether sublingual B12 would be more appropriate than oral given my current acid suppression medication. For high-dose omega-3, I'd like to discuss therapeutic dose omega-3 supplementation for cardiovascular and triglyceride management. I understand doses above 2 grams per day can interact with anticoagulant therapy. Can we review my current cardiovascular medications before I increase my dose? Let me bring this back to Leonard. After that first appointment, we ran his methylmalonic acid. It was elevated. His serum B12 had been reading normal for 2 years. His functional B12 at the cellular level had been declining the entire time. The PPI had been intercepting his oral supplement with clinical efficiency. We switched him to sublingual methylcobalamin, 1,200 micrograms under the tongue each morning while continuing the PPI under gastroenterology review. We added K2MK7 alongside his existing vitamin D. We switched his magnesium from the oxide capsule he had been taking to glycinate, timed to 60 minutes before bed. At his 3-month follow-up, his methylmalonic acid was normalizing. His B12 was rising. His leg cramps, which he had mentioned almost as an aside, never connected to the magnesium, were gone. He came in with the old bottle of magnesium oxide. He put it on my desk. He said, 2 years. I took this every morning for 2 years. I told 3 doctors about the leg cramps. Nobody asked what form of magnesium I was taking. Nobody asked what time I was taking it. He looked at the bottle. He said, I was doing everything right, except I was doing it wrong. That is the entirety of this video. Not that supplements do not work, not that the science is questionable, that the instructions were written for someone else. And after today, you know how to rewrite them for yourself. Before you close this video, I want to ask you one thing. What supplements are you currently taking? And when are you taking them? Put it in the comments. Not your medical history, just the supplement and the time of day. Because I want to show you something about the patterns in how people in this audience are taking their supplements, and whether those patterns match the biology. Your comment may be the thing that prompts someone else to make a change that has been waiting to happen for 2 years. If this gave you something your last appointment did not, subscribe. Free. First link below. When you write to me, I write back. Important. Do not skip this. Do not stop any prescription medication to improve supplement absorption without your prescriber's knowledge. The conditions those medications treat are real and the medications may be necessary. What can change is the supplement strategy around them, not the medications themselves without medical guidance.